So again, my chapter is on nutritional assessment and intervention preoperatively for spine surgery. I had 3 PICO questions specific to this chapter. The first is what preoperative serologic studies of nutritional status are predictive of adverse events after spine surgery? The second is what preoperative non-serologic assessments exist and are predictive of adverse events after spine surgery? And then the third is an intervention question that in patients who are malnourished, is there any preoperative treatment or increases the risk of these postoperative events? Again, here's the flow chart. As you've heard from the other speakers, we culled through many articles. Because this topic is actually relatively new, although studied in other surgical populations, it has not been well studied in spine surgery. And therefore, I only ended up with 13 articles to review. And I'll present just a few of those for you to help understand how we answered these questions. So the first question is, what preoperative serologic studies of nutritional status are predictive of adverse events after spine surgery? And I think we needed to start by looking at what are the adverse events that have been discussed in the literature associated with nutritional status. And we really found throughout the review of the literature that there were 3: surgical site infection, non-union, and hospital readmission. And then I can talk a little bit about the 2 tests that have been used mostly to study by going through the articles that we reviewed and that gave us our recommendation level. So the first is a study, probably one of the early nutrition status. It was published in 2015. It was a case control series, single institution, and they essentially looked at a cohort of patients who had been taken back to the OR after spine surgery for a washout because of infection. And then they matched them with control. So it was a case control study. Not surprisingly, if you can see in table 1, there were several differences between the cohorts, namely age, BMI, and some of the other factors, including the comorbid conditions and their levels fused. But also looking at the prealbumin, you can see that if your prealbumin was less than 20, there was 10% in the infected cohort, whereas 7% in the control cohort. But probably more importantly from this study, when they did a multivariable analysis, adjusting for all the differences between the groups, they still found that a preoperative prealbumin level less than 20 was predictive of a surgical site infection. This same group did a much larger study where they did a retrospective review of all elective posterior spinal surgeries, and again, looked at patients who had a deep surgical site infection defined by need for a washout. They had 387 patients included. And again, when you look at the malnourished patients defined by a prealbumin less than 20 compared to those that were had normal nutritional status, they had a host of baseline differences, which you would expect. Again, age, as well as some other comorbid conditions like diabetes. But again, despite the differences in their baseline cohorts, once you adjust for that on multivariable analysis, having a prealbumin less than 20, again, was predictive for surgical site infection. And if you look at it, the adjusted odds ratio was actually 3.28, one of the strongest predictors next to diabetes for surgical site infection in this patient population. The next adverse event that we looked at was non-union. And this is a single center series of 74 consecutive patients of 1 and 2 level lumbar fusions. And they actually got CTs on all the patients to assess their bony fusion and had almost a 20% non-union rate in this patient population. The impetus of the article was to look at bone turnover markers in the serum, but they also looked at age and other comorbid conditions, including malnutrition in these patients. And what you see is in patients with non-union versus patients with union, you look at the albumin level and they were statistically lower albumin levels 4.07 versus 4.31, which may not sound like a big difference, but again, those were statistically significant for non-union. As you may see, there are other things that come into play for non-union, including the bone turnover proteins and some of the other patient-level factors. But on the adjusted analysis, we again are seeing that our marker of malnutrition of albumin is significantly predictive of non-union in this patient population. The third adverse event that we evaluated was hospital readmission rates, and these could be medical readmissions or surgical readmissions. And this group did a single center retrospective analysis of prospectively collected registry data. They had 145 patients undergoing elective spine surgery that were included, and 40 of those were in the malnourished cohort. This cohort was defined by an albumin less than 3.5. And again, busy table on the right side, but I just want you to see that when you look at the preoperative baseline variables, obviously there are a lot of differences between patients who are malnourished and nourished, both in their demographics, but also in this cohort, some differences in the operative level variables, as well as the postoperative variables. But at the end of the day, again, on adjusted analysis or multivariable regression, we see that the preoperative albumin level is significantly predictive and independently predictive of 30-day readmission after elective spine surgery. This other study is an even larger. This is using the NSQIP database and looked at 30-day perioperative complications, prolonged length of stay, as well as readmission following elective lumbar fusion surgery. This was a much larger cohort study, 2,400 cases, and they had about 160 patients who were defined as a low serum albumin, which was a serum albumin of less than 3.5. Again, lots of baseline differences in age, BMI, smoking status, diabetes, operative level variables. But I highlight again that hypoalbuminemia or a low albumin was predictive on multivariable analysis of 30-day unplanned readmissions. In this study, they didn't see any difference in perioperative complications or prolonged length of stay. So as a recommendation, serum markers of malnutrition, including in the studies we evaluated, low preoperative albumin or prealbumin are associated with multiple adverse events. And therefore, in at-risk individuals, clinicians should assess the nutritional status preoperatively and counsel their patients on the potential for these adverse events. The second question we had were what preoperative non-serologic assessments of nutritional status are predictive of adverse events after spine surgery. And unfortunately, we did not find a single article using any non-serologic study like any measure of nutritional status, which there are several calculators as well as calipers that are used in the other literature, but none specific to spine patients. And therefore, there was insufficient evidence for any recommendation on this topic. Our last question had to do with an intervention. So if patients with malnutrition, does any type of preoperative intervention or treatment decrease the risk of postoperative events? And unfortunately, there was no studies that actually looked at an intervention in patients who had low albumin or prealbumin prior to surgery. But we did evaluate one study that looked at a multimodal nutrition management plan in patients with normal nutrition prior to surgery. It was a prospective randomized control trial. There were 187 patients, and the multimodal nutrition group got a perioperative nutrition protocol, including protein and carbohydrate loading prior to surgery, as well as specific nutrition after surgery in the first 24 to 48 hours. The outcomes that were looked at were need for albumin post-op, blood transfusions, and electrolyte abnormalities. They also looked at some complications in length of stay. As you can see in the table 2 on the right, the patients in the multimodal nutrition group did have decreased amount of need for albumin. They also had decreased electrolyte abnormalities. And probably more important to us, something that they did measure was wound drainage, and they saw a significant decrease in the amount of wound drainage. Again, probably a factor of the patient's nutritional status in the multimodal nutrition management group. So for this PICO question, unfortunately, we couldn't there was insufficient data to have a recommendation because there are no studies out there looking at an intervention in patients with malnutrition to start. So areas for future research, I think we are just at the inception of understanding all the factors that go into really optimizing our patients preoperatively for elective spine surgery, and nutrition is one of those places where we can make big gains. So we need to ascertain cutoff values for preoperative albumin and prealbumin. Those are the two most common serologic studies used. I think we also need to investigate if there are other non-serologic assessments that might be either more predictive or as predictive in their impact on adverse outcomes after spine surgery. And lastly, I think it is incumbent upon us to develop and evaluate specific nutrition protocols, not only to improve malnutrition, just like Jim talked about with the hemoglobin A1C, but also then assess whether we can impact and avoid adverse events following spine surgery.